Okay, good morning. Thank you all for participating in today's media briefing, our 27th since the start of the pandemic. These press conferences are a reflection of UPMC's ongoing commitment to provide timely and accurate information for all. I'm joined today by Dr. Graham Snyder, UPMC's Medical Director of Infection Prevention and Hospital Epidemiology, Dr. Erin McCreary, UPMC Infectious Diseases Pharmacist and Clinical Assistant Professor in the University of Pittsburgh Division of Infectious Diseases, and Dr. Don Ely, UPMC's Chief Medical Officer and the Chair of Emergency Medicine. They will share new data on COVID-19 treatments that prevent hospitalization and save lives, and provide an update on UPMC's COVID-19 vaccination in the communities we serve. After their remarks, we will take your questions. Dr. Snyder.
We have a lot of positive news to share today. Welcome news at a critical time, with a rise in COVID-19 cases and the emergence of new virus variants. Let me first start with some numbers about UPMC's COVID-19 vaccination efforts. To date, UPMC has given more than 297,000 COVID-19 vaccine doses here in Pittsburgh, Butler County, Lancaster, Erie, and all of the communities we serve. More than 166,000 of these went to people not affiliated with UPMC, more than any other health system in the state. UPMC administers 25,000 to 35,000 vaccines a week, and we have the capacity to administer 100,000 vaccines each week if we get the necessary supply. While we all love seeing the media coverage of our stadium-based vaccinations in partnership with our beloved sports teams, UPMC remains committed to the community-based clinics you may hear less about, with faith-based groups and other partners in places like Wilkinsburg, Harrisburg, and Erie. Vaccination is just one important layer of protection in our effort to end this pandemic, with critical and effective measures of masking and distancing also playing an important role. Nationwide, while case numbers are down from last year's holiday surge, the current increase in COVID-19 cases nationally and in our region is driven by laxity with masking and distancing, and likely also driven by the emergence of COVID-19 mutations and variants, such as the more transmissible UK and California variants, which may also be more likely to cause serious disease. More transmissible variants are present now in our communities. Vaccines may be adaptable to changing variants, but we must have another layer of protection. Effective treatments for those who get sick to prevent serious complications is a key part of the strategy for putting the deaths and severe illnesses caused by this virus behind us. Since the very beginning of this pandemic, through our REMAP Learning While Doing program, UPMC has led the charge in developing evidence-based treatments for people hospitalized with COVID-19. But our focus should also be with those who have COVID-19 but are not yet sick enough to be hospitalized. Today, I'm happy to share the latest on monoclonal antibodies, a treatment that, if given early after developing infection, to keep you from becoming seriously ill. Monoclonal antibodies are a type of medication that is given in a one-time intravenous or IV infusion. There are 3 monoclonal antibody treatments authorized by the FDA for use in COVID-19 patients at higher risk of developing severe disease. We estimate that about a third of our patients who are positive for COVID-19 would qualify. This is a treatment that was given to former President Trump shortly after his COVID-19 diagnosis. To date, UPMC has given this treatment to more than 1,000 patients in all of the communities that we serve. While giving this therapy as part of care and not a clinical trial, it was important for us to understand how effective this treatment has been for the patients we care for. By comparing the outcomes in our patients who receive monoclonal antibodies to patients who qualified but for whatever reason did not get the treatment, we observed that monoclonal antibody cut by nearly 70% the risk of hospitalization or death. The possibility that a treatment can prevent serious complications of COVID-19 would truly be transformative for this pandemic. Dr. McCreary, one of the co-authors on this research paper, will tell you more.
Thank you, Dr. Snyder, and it's truly a joy to be here today to share some of our results. So a team of my fellow clinician scientists and I are posting our findings to a preprint medical server called medRxiv. We will also pursue a peer-reviewed publication of these results, which is the traditional route for sharing academic data. But because our data and our information about this treatment is potentially life-saving and, as Dr. Snyder said, really transformative for this pandemic, we are telling you now. So our data show that monoclonal antibody treatments have kept our patients with COVID-19 from needing to be hospitalized, potentially sparing them from long COVID-related disabilities and even death. And as Dr. Snyder said, if you qualify for this treatment, our data shows that it cuts the risk of hospitalization or death in our patients by 70%. So what are monoclonal antibodies if we're talking about this treatment? Well, mono means one, and clonal means copy. So what these are they are copies of antibodies that seek out the COVID-19 virus in your body and block it from infecting your cells and replicating. So essentially, we're giving your immune system a leg up on the virus before it can take hold and wreak havoc. We believe that this treatment works most effectively if given early after your initial COVID-19 infection or exposure. So ideally within 10 days of your positive test result and mild symptoms. In fact, our results show that for our patients, if they get treated within 4 days of symptom onset, that's when they have the best results. So really the earlier for this therapy, the better. Right now, we're authorized by the FDA to give this treatment to patients who are most at risk for severe complications of COVID-19. In general, these are our older patients, 65 and older, or younger patients who are obese or have another condition that may increase their risk of a bad outcome from COVID-19. These conditions include things like diabetes, heart disease, lung disease, and kidney disease. As Dr. Snyder said, we believe about 1/3 of our patients diagnosed with COVID-19 in our communities would qualify for this extremely beneficial treatment. And if the research done by our scientists and others continue to indicate this kind of effectiveness, we will advocate to continue to expand our resources to provide access to people with whom monoclonal antibodies may benefit. Now, if you're listening, you may be a little nervous about the idea of this treatment because it is a new kind of sounding thing. And like all medications out there, there's always a risk, so that nervousness is completely understandable. But I am here to reassure you that the rate of reactions from this medication in the patients that we've treated has been extremely low, and only a handful have had any kind of mild reaction at all, and no patients have required hospitalization from the infusion of the antibody treatment or from a reaction to the medication. And while you're receiving this infusion, all patients are monitored at all times by our phenomenal team of caring clinicians. So as a pharmacist, I would advise most patients to get monoclonal antibody treatment if they qualify. I can promise you from seeing patients throughout this pandemic, the risk of COVID-19 related complications is far higher and much, much worse than the risk of a reaction to the medication. So I think we're displaying a map right now, and you can see that we offer this monoclonal antibody treatment at 16 dedicated infusion centers across the Commonwealth and in New York. For our patients who are homebound or who may not have transportation to one of these infusion centers, we can come to you and do this infusion from your home. We can also do this in our nursing homes and our senior communities, as well as our behavioral health centers for patients who are currently undergoing care for any kind of mental illness. I want to emphasize that if you qualify for monoclonal antibody treatment, your location is not a barrier. We will help you get access to care.
Thank you, Dr. McCreary. And I thank you for saving an important last location for this exciting and potentially transformative care to be delivered. Of the many hats that I wear, I'm chair of emergency medicine at UPMC and the University of Pittsburgh. My partners and I see people at key moments of health or illness, and that is the appearance of either new symptoms or illness or new needs that are more severe. We all hope that vaccination, masking, and distancing will keep COVID-19 infections lessened. But we know that those efforts will leave some people who need added help. This is why our current focus on this new novel therapy is so important. our data show that the earlier you get this treatment, the better your outcome is. And we can now deliver this therapy right in UPMC emergency departments if you qualify. We don't have to refer you anywhere else. Another point I want to stress is you don't have to be really sick to get monoclonal antibody therapies. In fact, we want you to get your treatment as early as possible, particularly when your symptoms are milder. Waiting too long simply limits the opportunity for benefit. Too many times, we've seen people with what they thought was mild COVID-19 for the first week quickly take a turn for the worse and end up in our hospitals or even in our ICUs. We have something now that will dramatically drop the likelihood of that occurring. Don't let that case of delaying with mild symptoms be you or one of your loved ones. Don't let cost be a barrier to you. The medication is free. UPMC Health Plan waives all other fees for our members, and many other insurers do the exact same thing. In addition, our innovative scientists are developing the next generation of monoclonal antibodies. Dr. John Mellors and his team are refining their highly potent monoclonal antibodies that may outperform the current therapies, and they might even be easier to deliver and administer. They expect to get those monoclonal antibodies into clinical trials in the near future. And they've developed, in addition to not only the specific antibodies, a powerful discovery engine that can create additional monoclonal antibodies as new variants arise and as we learn more about COVID-19. Finally, in addition, we are working closely with our partners at the Allegheny County Health Department and other public officials in Erie, Harrisburg, and throughout the communities that we serve to help raise awareness of the existing monoclonal antibody therapies in all who test positive for COVID-19. If you get a positive COVID-19 test, whether you're a UPMC patient or not, we want you to know about this option and know where to get treated if you make this choice. Ask your doctor, contact us, or talk to your health department. Ask about this therapy. We want you to have the opportunity to get better quicker. Where can you find out more information? What do you do if your physician doesn't know where to refer you? There are some simple options. First, you can go to upmc.com/antibody treatment. Or you can just search UPMC and monoclonal antibodies. You'll get to the same spot. Another option is to call toll-free 866-804-5251. That's 866-804-5251. Remember this one thing. If you get COVID-19 infection, ask your doctor about monoclonal antibodies. It just might save your life.
Okay, thank you, doctors. And now we'll take questions from the media, all of whom are rejoining us, or who are joining us remotely online. To ask a question, you'll have to go to the participants icon at the bottom of the page and press the Raise Your Hand button. That will put you in the queue. I will read your name and your line will be unmuted for you to ask your question. We will try to call on as many different media outlets as we can in the time we have allotted. So again, go to the bottom of your page, press the Raise Your Hand button. That'll put you in the queue. We'll unmute your button. Please be sure to unmute your sound on your end. First question comes from Paul Goff, Pittsburgh Business Times. Paul, please go ahead.
Hi, thank you very much for taking the time. I wanted to check about, you mentioned the rise in cases and the variants. Hospitalizations also seem to be up. Where are we at this stage, and how much sicker are the patients that you're seeing, and are any of them vaccinated?
Graham, you want to take that?
Yeah, we're seeing an increase in cases probably for two different reasons together. One is, as a community, we must mask and distance even after we've been vaccinated, because that is the foundation for safety. I think the other reason that it's contributing, and how much is hard to say, is the rise of new, more transmissible variants. So what we don't entirely know about is how people respond to these variants as far as the degree of their illness. So far, we have not been able to find a different clinical pattern in the people that we're admitting to our hospitals, but these are emerging variants, so we'll continue to observe. The vaccines are performing as we expect. It is very unusual for somebody to be very ill after a second dose of vaccine. And so far, we haven't really identified many cases, if at all, of people who've had serious illness after their second dose of vaccine has been completed, plus the 14 days afterwards. So in clinical practice, I think the vaccines are working as we expected them to.
Thank you. Next question comes from Marilyn Marchione of the Associated Press. Marilyn, please go ahead.
Hi, thanks very much. Two questions, if you can, please. Why do you suppose the uptake and use of antibody drugs has been so much less than what was anticipated? And the second question is, looking across the spectrum of treatments for COVID-19, where are our greatest needs? What do we still need that we don't have yet?
Dr. Lillys?
Well, that's an excellent question, and I thank you for asking it. And I have to tell you, when monoclonal treatment was first authorized by the FDA, we thought there would be such high demand and it would be given by so many healthcare providers that there would actually be a shortage. And so we prepared to deal with the fact that we would maybe not have enough to deliver to everybody who was asking for it. We planned a lottery system so that we could do this equitably, and it wouldn't just go to the most well-connected patients. We were surprised when so few other healthcare systems either offered it or offered it with any enthusiasm. UPMC ends up being one of the few places in the state giving large amounts of this, and it has the most coordinated and equitable distribution system. And we've actually just shared a paper showing others how we built this distribution system. We think it had to do with other healthcare systems and providers having difficulty being able to invest the infrastructure, the staff, and the processes that are needed to administer the medication. That created lower awareness not only among the treating physicians and advanced practice providers, but also among patients and other clinicians. This is really life-saving therapy. We think it has tremendous opportunity to be used more and more, and we're hoping that these kinds of conversations stimulate more people to ask, and we will deliver the monoclonal therapies.
Thank you, Don. Next question, Angie Moreski from WPXI TV. Angie, please go ahead.
Hi. Yes, I appreciate you taking our questions. The monoclonal antibody treatment, I know, has proven quite successful. You're talking about 70% preventing hospitalizations and deaths. Do we know how effective it's been for treating the variants?
That's an excellent question, and there's recent data from the government coming out now to suggest that we should be pivoting to use combination products, which would be using two different kinds of antibodies to treat patients at the same time. So essentially you'd put both antibodies in one infusion and treat one time over what we consider a monotherapy product or only one antibody. So intriguingly, our data was with one product. The first product we received was one drug, and that's what we used to treat our patients, and we saw such tremendously positive results. Now, these patients were treated in November, December, January, and so perhaps that was before we saw a lot of these circulating variants. We simply don't know, but we have no reason to believe that the monotherapy product was not effective because we demonstrated that it was, but we have already reacted to these new data as we have throughout the entire pandemic, evaluating literature as it comes out and pivoting as needed to rapidly treat our patients with optimal care. So we at UPMC are shifting now to administer only the combination products, of which there are two treatments available. We offer both combinations to our patients.
And to add to that, I think this is one of the real benefits of an academic medical center that's integrated with healthcare delivery and actually even insurance that we have here at UPMC. We don't just deliver what's already been authorized. We actually observe and create the new insights that drive these kinds of observations. The virus will continue to change. We will have to adapt to it. We'll test not only what's available, but what we're creating, and be sure that we stay ahead of this and deliver the best care today, tomorrow, and next month.
Yeah.
Thank you. We have an email question from Mark Koshkarian at Spectrum News in Buffalo, New York. Is the monoclonal antibody treatment available at UPMC Chautauqua in Jamestown, New York? What kind of impact is it having on preventing hospitalizations there? And lastly, a vaccination update on UPMC Chautauqua and the message to those still waiting in more rural communities.
I can probably take the antibody part if I know you want to take the vaccine part. But yes, the monoclonal antibody therapy is available at all of our UPMC sites. So Chautauqua, Jamison, Hammett, all over, you can get these therapies. When you are referred, patients actually get to select their first and second choice infusion center. And so we try, and then we schedule you within the day to get you into the best and easiest convenient infusion center for you. And all of those patients were included in our data to show this benefit.
And regarding vaccination, each site that delivers vaccines gets that through their state. And so obviously at UPMC Chautauqua, the New York, not only guidelines about who gets vaccinated and when, but the supply comes from New York State, which will vary in some ways from what happens in Pennsylvania. What I can promise you is that we will ensure that every dose of vaccine that we get is quickly administered into people in the areas in which it's been delivered. UPMC's chosen an approach that uses both small and large-scale vaccination opportunities to make sure that we don't leave any part of the population behind. We will deliver the vaccine that's available. We can deliver many multiples of what we're getting right now. The key is for the individual manufacturers to get that to the federal government, then to the state governments. What we'd advise people in places like Chautauqua or any other more rural location, keep your enthusiasm about getting vaccinated. Get whatever vaccine you can when it's available. Don't worry about which one. Wear your mask still and even after your vaccine. That's still incredibly important. We're not at the end of the story yet.
Okay, thank you. Next question, David Winter, Penn Live. David, please go ahead.
Thank you. I'd like to ask two questions. The first one has to do with the variants. As of late this week, the Pennsylvania Department of Health has been not very definitive regarding the presence of the variant, pointing out things like the lack of ability to test for it at the local level. And when I checked the CDC recently, the number of cases attributed to Pennsylvania didn't seem very high. So what I'm asking is, what are your views about the prevalence of it in Pennsylvania, and what do you base that on, and do you attribute any special characteristics to it, like such as the ability to spread faster? And I know that's kind of a long question, but just so you know, I'd also like to ask about the cost of the monoclonal treatment. If it's available to everyone, if there's any, well, I'll let it go at that. I'm wondering how much it costs and if there's any potential barriers regarding cost. Thank you.
I'll answer the cost question first, and then I'll talk about what the variants mean for our communities. Monoclonal antibody is provided by the federal government, so there is no cost for the monoclonal antibody. And most health insurance companies, including UPMC Health Plan, are waiving charges for their health plan members, for their insurance insurees. So as a individual receiving monoclonal antibody, odds are very good that there'll be no cost to you. As an organization, we see providing monoclonal antibody as part of our public service. Our investigation into how our patients have done with monoclonal antibody was largely to answer for our own satisfaction, how well does this work? Should we expand this service that we're providing? And as Dr. Yearley mentioned, no matter what provider can offer you the vaccine or the monoclonal antibody, and for that matter, no matter which vaccine you get or how we adapt the monoclonal antibodies that are on the market, these are both really effective interventions, and you should be thinking about them.
Yeah. Before you talk variants, I'll jump in because a lot of phenomenal people behind the scenes, we often don't realize, but we have an entire team of people at UPMC that work with insurance companies to try and get everything covered and talk about that. And there's like a whole team that works on that. So if you come to our centers, we're working as hard as possible to ensure that everything is taken care of.
I want to put new variants in context. From the very beginning of the pandemic, this is a virus that has evolved. Now, the virus is evolving more significantly or in more significant ways than we initially appreciated at the very start of the pandemic, but nobody is surprised that there are mutations and that these mutations may accumulate in a particular strain or family of the virus. There are a couple things that these mutations may result in. They may change how the virus makes people ill, so it may make it more effective for the virus to cause you to be sick, or it may change how the virus is transmitted. For example, if you are contagious with more specific pieces of virus, you may be more contagious. We take as much information as we can from the global scientific effort to understand what these new variants mean. But I don't want us to get caught up on any specific variant because it's part of an ecology of virus, a constantly changing environment of viruses. And as an individual wondering, should I be worried about the variant? What do I do differently? The answer is we do the same thing. We do the masking, we do the distancing, because those are, whether you're vaccinated or not, fundamental interventions. If you have an opportunity to get the vaccine, all three of them that are available in the United States are fantastic vaccines. And if you are diagnosed with COVID-19, talk to your doctor about the possibility of monoclonal antibody therapy.
Thank you. Next question, Bill Kibler, the Altoona Mirror. Bill?
Thank you for taking this. Can you say how many non-medical workers UPMC has vaccinated? And number two, have you considered holding mass vaccination clinics?
We have.
And if not, why not?
So, Graham, while you're pulling those numbers together, we actually have done mass vaccination clinics. We have done a few platform sessions at various sites at all the communities we serve, particularly here in Western Pennsylvania. We plan to do more of those, often partnered together with either the county or another sponsor. But we think it's important to recognize that while the mass vaccination sites achieve lots of volume and often a lot of attention, that if we're going to serve everyone in our community well, we have to have multiple vessels, as it were, to get vaccine to people. And that means many more smaller efforts, whether we host them at a physical location or we go out to you. Those are the kind of incredibly important things that allow us to equitably distribute vaccine and make sure the most vulnerable get it. They're the kind of things that aren't seen as much. So yes, we have done it. You've seen, for example, at the UPMC Lemieux building. You've seen at PPG Place or PPG Arena downtown. You've seen at the South Side, large scale, where over 1,000 people came through and got vaccinated. But the real secret sauce are those smaller efforts that are out there getting people who are the most vulnerable, who can't get in. One of the ones we're most proud of is in Erie. We went and found a community where there was an intense number of people over the age of 90 not connected to the internet. We found them out, got them vaccinated. I'm fearful people like that would just be left in the lurches if we didn't have these kind of focused activities. So the answer is we're going to do all of these things.
Yeah, you'll see us at PPG Paints Arena April 1st, again, with the next step in our partnership with the Penguins. You'll also hear about us with Bethany Ministries in Homewood, with Hosanna House in Wilkinsburg. In North Central Pennsylvania, you'll see us with partnering with North Central Site Services to reach elderly high-rise communities. We'll work together with the Harrisburg Housing Authority in our state capital. These are examples of what you're going to see pretty soon that are all examples of what Dr. Eli is talking about.
And we just did a 2-day event with the Harrisburg Area Community College.
Yeah. And I will say, as a pharmacist who's been vaccinating in these vaccine clinics, which is absolutely the happiest place on earth to be right now, is at the vaccine clinic. We do 1,500 to 1,800 people a day sometimes in some of our standard routine clinics. And so you could argue that every day is a mass vaccine day as we're trying to get as many shots in people as possible.
Dr. Snyder, do you have the figures on
Yep.
how many non-healthcare workers have been vaccinated?
Yeah, 297,000 vaccine doses total. 166,000 of them have been people not affiliated with UPMC, and I'll add a couple other numbers that I think are telling. 11,054 doses to residents and staff of long-term care facilities. I call that out because the elderly with this virus are those who are truly vulnerable to complications of disease. And so protecting those vulnerable members of our friends, family, and our community are important. There's demand too. So as an epidemiologist, I'm really excited about how our communities want the vaccine and see it as a part of the end of this pandemic. On our online registrations, we have almost 458,000 requests, and we have over 81,000 people scheduled for vaccines.
Okay, thank you. Next question comes from Mick Stinelli, Pittsburgh Post-Gazette. Mick, please go ahead.
Hi, thanks for your time. I had another, vaccination number question. I think earlier somebody mentioned that UPMC is doing about 25,000 doses delivered a week. I was wondering on average how many doses UPMC is getting a week, and if they're using all of them that are available. Is there anything being wasted or thrown in the trash, so to speak?
So that's a great question about vaccine supply. And again, remember, all of our vaccine comes through the Commonwealth of Pennsylvania and the Department of Health. Secretary Beam, who has taken over as in the Department of Health, has been a fabulous partner with both communication and efforts to not only increase the supply, but to make sure we know about the supply, and the supply is going to sites that keep the promise. In other words, they deliver vaccine quickly, efficiently, and nothing's wasted. We strive to not waste a singular dose. This is an incredibly precious resource. We know it, you know it, it's incredibly important. I think the number of doses that couldn't be delivered would be infinitesimally small. I couldn't tell you zero, but we really work hard, and it's why we plan in advance and we have scheduled appointments. When you show up, you will get a vaccine. Period, end of sentence. That's been our mantra from the beginning and continues to be what we're doing right now. Wastage is simply not an issue right now, although I can't quantify the specific numbers. And it's something that we're vigilant about every singular day. I think Dr. McCreary can point out, with her hands-on experience at the clinics, how serious this is taken.
We are getting every last drop into patients, I can assure you, counting vials and ensuring that amount of vaccine equals patients present so that not a single dose is wasted.
Okay, thank you. Next question, Grace Gifferton at WPMT TV in York, Pennsylvania. Grace, please go ahead.
Hi, thank you. Going back to the monoclonal therapy, at what point should a person seek this out? I guess I kind of have a two-part question. And how frequently is UPMC using this therapy? I guess per day or weekly? And what would you like to see numerically? How many more people would you like to see seek out this treatment?
Yeah.
So you should reach out for monoclonal therapy as soon as you know you have the infection. And you can ask, am I eligible for it? Not everyone is eligible for the therapy under the current authorizations. There's some criteria. We can walk through that with either your physician or if you call us directly. Don't wait to ask about it, particularly if you're elderly, if you know that you have serious conditions. You've asked how many. We've given a little over 1,000 treatments of monoclonal antibody therapy. Remember, monoclonal antibody therapy really wasn't available until the beginning of December. We have been increasing our numbers over the past few weeks because of our efforts in getting the news out. And this was in face of, up until just recently, the numbers of people having COVID-19 were dropping. We think that there is a tremendous reservoir of people who are not getting this incredible transformative breakthrough right now. So we told you about a third of the people who are contacted are eligible for the therapy, most of which, 2/3 of which end up getting the therapy. We think we could multiply that many times over. We've been trying to partner with the county, with other healthcare systems around to say, this is available. We will do this for you. And we're trying to get the word out through sessions like this to make sure everybody knows about this option. If you feel sick and have a positive test, call us right away.
We have the capacity across our 16 centers to infuse up about 300 patients per week in terms of chair time, and then monoclonal antibody therapy is available in every single UPMC hospital emergency department, which also significantly expands our access. And then in terms of our outpatient, I said 300 patients per week across the system, but we are ready, willing, and able to expand that should demand increase. So we're quite prepared for any kind of increased need should it arise. I couldn't agree with Dr. Eli more that if you have mild symptoms and are within 10 days of your COVID diagnosis, you should ask for monoclonal antibody therapy or at least explore it.
Dr. McCurry, you mentioned that there's more than one monoclonal antibody treatment.
Yeah.
Is one better than the others?
Yes, we do have more than one. So currently we have three, a monotherapy product and then the two combination therapy products. We discussed how we're transitioning to only offer the combination therapy products in light of the data about the variants. So we have two therapies available, one from Eli Lilly and one from Regeneron. No one knows if one is better than the other, so that's what we're seeking to find out. So we are currently evaluating that in our learning while doing model to see if there are certain types of patients or certain benefits to the different therapies. And so patients have access to both, and we are actively collecting data to find that answer. We're committed to looking at it in real time.
Next question, Sarah Bowden, WESA FM. Sarah, please go ahead.
Hi, thanks so much for your question, for answering my question. So a lot of people I've been speaking to this week feel that it is far past time for Pennsylvania to pass out of the 1A and go into 1B and 1C. And I've heard lots of rumors of people saying, hey, UPMC, AHN, they don't really care if you're 1A, just say you're 1A. They just want to get a shot in the arm. I'm curious to take your temperature. Is this true? And do you think it's time to phase into 1B or 1C or maybe even open up vaccinations to everyone?
That's a great question. I think it's important to understand why priority lists exist. And it's because the supply right now does not meet the demand if the demand is everyone in a particular location or in the Commonwealth or even across the country. If there was enough supply, simple logistics and scheduling would be the only issue. The supply continues to increase from both the two original vaccines that were available and now the third. We get more and more. The real answer to the impatience and the desire to get vaccinated isn't so much in changing priority lists. It's about getting more of that vaccine to the vaccinators, particularly the people that can do the job effectively, efficiently, and equitably. And we think we meet all of those criteria in our design, and we're sure there's others that meet that too. I don't think the real benefit will be in shifting those priority schedules. Once the vaccine supplies continue to grow, continue to get into individual arms, those will change very, very naturally. So I think it's actually almost not the most important question right now. It's how can we continue to get supplies and then get those into people?
Okay. Thank you. Next question, Marcy Cipriani, WTAE-TV. Marcy, please go ahead.
Hi, my question is about the criteria. You mentioned certain criteria in order to be allowed this treatment, but you also mentioned it's not in high demand. Is there any possibility of changing the criteria, offering it to more people, younger people, other people?
So the criteria are set by the federal government. It's called an emergency use authorization that gives us these therapies, and we have to treat patients within those set criteria. Currently, those criteria are any patient age 65 and older, any patient aged 55 and older who has another comorbid condition like diabetes or chronic kidney disease or things like that. It's also available for adolescent patients, so patients aged 12 to 17 that have a comorbidity such as sickle cell disease or who may need respiratory support or machines that help them breathe. So any patient aged 12 to 17 is able to get it under those. And so those are the criteria that we have to follow, and those are the patients that are at most risk of progressing to severe COVID-19 disease.
One of our goals in our efforts to not only use the authorized antibodies, but to be the developer of new antibodies and new ideas about the existing antibodies is to achieve exactly what you asked, is to help us not only deploy what's available now, but to frame out how this could be more broadly used and more smartly used. So I think it's a fabulous question. We want to be part of that learning process. not only learning how to use what we know about today, but what might be more available tomorrow. We think that this could be expanded, but it's going to take systematic and careful collection of evidence, and that's what we do well.
Next question, Maria Simbra, KDKA TV. Maria, please go ahead.
Good morning.
Good morning.
Good morning. Just to follow up on that, so for people who do not qualify for the monoclonal antibody treatment, are there options that you can present to them in early illness or studies that they can participate in?
We are right now planning new trials in the monoclonal antibody space to look at other indications. Because they're new, that requires much more oversight and approval. So as of today, all the treatments are within the emergency use authorizations, but we want to be a part of that process and have that fit right into the same basic platform you've been hearing about that we've been using throughout the entire pandemic to learn as we do. So it's a great question. It's a very forward-looking question.
Dr. McCreary co-leads a very, very smart and hardworking group of UPMC providers who are constantly reviewing the data and providing guidance to our UPMC doctors and advanced practice providers on what therapies are most effective, not just in the outpatient setting, but in the inpatient setting as well. This is evolving fast with this pandemic, and they have a mighty job to do, but they're doing it well. So the answer to your question about what's available to an outpatient if monoclonal antibody will probably be different within a week's time.
It does seem to change week by week, but we do keep all of our prescribers abreast of all of the ongoing outpatient clinical trials, how to enroll patients, and any other therapies that may be beneficial. At this time, other than monoclonal antibodies, there is no slam dunk therapy for outpatients, unfortunately, outside of symptom management. But as Dr. Ely said, we're working to ramp up even more trials to discover even more effective therapies.
Okay, we have a follow-up question from Angie Moreski at WPXI. Angie, please go ahead.
Hi again. I just wanted to follow up. We were talking about the U.S. government stopping the distribution of the Eli Lilly monoclonal antibody treatment. And just wanted to find out, since that was part of the drug that you guys were using in your treatments, is that going to impact availability? How has that impacted your program and your ability to provide monoclonal antibody treatments?
It's an excellent question. So Eli Lilly makes two monoclonal antibody products, bamlanivimab, which we administered as monotherapy, and that's what our data show, and then istevimab, which is a newer antibody that just got emergency use authorization in February. So it's not so much that they're stopping distribution of bamlanivimab, it's that they're recommending now that it only be administered in combination with istevimab to try to combat some of those variants that we've described. And so we will be transitioning our patients to receive only combination products moving forward in light of these new data. But as I said, our patients did very well with bamlanivimab monotherapy. That was a couple of months ago, but we will transition to combination products.
I'll put my epidemiologist hat on again and say this is 21st century science. The fact that we've talked about this before, that we have vaccines with different technologies developed so quickly that are incredibly effective, very safe, is amazing. And the fact that we have multiple monoclonal antibody products that, like vaccines, will adapt to the changing virus, and we're very proud that our colleagues are contributing to that science, is really amazing for us as a society. So we will see as the virus evolves and as the pandemic changes, we may see changes in what vaccines and monoclonal antibodies are effective, but we will stay up with those and offer what's most effective for what we have available and what's circulating.
Okay. And our final question is a follow-up from Sarah Bowden at WESA. Sarah, please go ahead.
Here's my follow-up question. So for people that aren't, who are under 50 but over 17, are there any other additional treatment options for them at this time? And also, what is the scientific reasoning for limiting the EAU to these age populations?
Yeah, so for the current emergency use authorization for monoclonal antibodies is determined by the federal government. The federal government has scientists that review the available data from the clinical trials that they were based on. And because it's an emergency use authorization and not an approval, we have to follow those guidance. It's not like a typical medication that's approved where a doctor may choose to use that medication for a different reason than it was approved. So here's an example of where we have to follow the guidance that we get from our public health and FDA authorities. Now, for younger individuals who don't meet the age criteria, and if they don't have an underlying medical condition that would qualify them for monoclonal antibodies, if they're an outpatient and they have mild disease, we don't have an alternative therapy for them. However, there are a whole host of therapies that are probably at this point too numerous and complicated to rattle off if somebody becomes more severely ill, like if their oxygen drops or they require hospitalization. And those are the therapies that Dr. McCreary was talking about that we make sure our providers are up to date on, and that as an organization we do the best we can to contribute to the science of what's most effective.
And then in terms of, thank you, Dr. Snyder, for that. And then in terms of why increasing age, does that make you eligible? Why is that the criteria right now? We know as patients age, immunity tends to wane. And so monoclonal antibodies are a form of what we call passive immunity. And so it seems that in administering passive immunity to patients with perhaps less immunity is more of a benefit. So treating those patients results in greater benefit. But like we said, we're looking to explore using antibodies beyond the current emergency use authorization in our clinical trials to see if there are other patients who benefit as well.
Okay. Thank you, doctors, and thank you all for attending. In about 45 minutes, we will email media attendees a link to download high-definition footage of this entire briefing, which we do encourage you to use in your news reports. If you have any follow-up questions, please contact UPMC Media Relations at upmc.com/media, and please remember to follow @UPMC News on Twitter for frequent updates. Thank you.